Hello, everyone. My name is Dr. Ramzy Rimawi. I'm an assistant professor of medicine at Emory University Hospital for the Division of Pulmonary and Critical Care Medicine. At Emory, I co-chair the Resuscitation Committee and Sepsis Committee. I'm board certified in internal medicine, infectious diseases, and critical care medicine. And so when it comes to sepsis, this really hits home for me in regards to the ID aspect of things, prescribing antibiotics, antibiotic stewardship, the impact of antibiotics on sepsis, as well as the non-antibiotic impact that sepsis has in terms of resuscitative measures and pathophysiology. And so when it came to a topic like SeptiCyte, really that hit home for me on many of the foundations that I believe in when it comes to sepsis. So we're going to start off with a classic example that we have. So this might be a little bit different to what you're used to seeing, but for example, in this patient, this specific case, this is a 45-year-old male landscaper who comes in with altered mental status, dry cough, dyspnea, after working in a hot weather condition. You might get something a little bit different. You might get someone who's after a traumatic incident, or maybe after being exposed to excessive stress. But what you're dealing with is someone who you're not quite sure, are they sick? Are they not sick? They're a little bit confused. They might be coughing. And so you're checking their vital signs, and you might blame that temperature on the fact that there's extreme hot weather. They might be tachycardic. There might be a drop in the blood pressure. And when you start drawing labs, you'll see that the white blood cell count is high. And maybe there's evidence of some end organ dysfunction with a creatinine being elevated at 1.6. And so now really sepsis is, or at least SIRS is starting to work on your brain. You're not quite sure where to go with it. And so what do? You order a chest x-ray. And now, so what are you getting? You're getting a chest x-ray. This is classically in an institution where you get a chest x-ray, and after about 2.5 hours, you're able to see that, okay, something's going on there. There's this dense consolidation in the right lower lobe. I have this patient who has a leukocytosis, has a fever, has a low blood pressure. Okay, now, because they have low blood pressure, I think they have severe sepsis. So you call this severe sepsis. What are we classically doing in a hospital? You're ordering antibiotics, you're giving fluids, you're checking the procalcitonin, you're checking the lactate. These are all the biomarkers we're familiar with that are FDA approved. Procalcitonin, lactate, CRP. You're getting blood cultures, urine cultures, sputum cultures. You're ordering a lumbar puncture, and then you're going to consult infectious diseases because you're hoping maybe they might be able to help you with some of the antibiotic prescription that you want. So tests start coming back, right? And so at our institution, we assess how long does it take, even when ordered stat, how long does it take for a blood test to be drawn, collected, sent to the lab, and the lab to report it. It's generally, even when ordered stat, it's about 4.5 hours. Most institutions are about the same, right? So you're going to draw your labs, you're going to get it sent to the lab, and it's going to be reported sometime about 4.5 hours later. You're going to start to get these tests back. And so your procalcitonin comes back and it's elevated. Your lactate comes back, it's elevated. Your CRP level comes back, it's elevated. Now you were supposed to give antibiotics, but because the chest x-ray took 2.5 hours from the time it came in, you ordered the antibiotics, and now the nurse has to get it. She has to infuse it. You went ahead and got it at 6.5 hours by the time your antibiotics are given. You're supposed to give 30 cc's per kg within a 1 hour period or a 3 hour period according to your bundle. And now it took 8 hours for that to go in. Your cultures, because it was delayed, your suspicion was really your confirmation that there was sepsis there was delayed. So it took 4.5 hours to get blood cultures. The patient hasn't urinated yet. They're a little bit dehydrated, and so that you haven't been able to get a urine culture yet. You ask the patient to cough up something for a sputum culture, but remember, this is a patient who came in with dry cough, and so they're unable to expectorate anything. You're asking for a lumbar puncture, but go figure. The hospital's out of LP kits, and this might be the middle of the night, and the ID doc is gone for the day. So now you're back to square one. What happens? About a day or 2 days later, this is what we get. I'm chair of a sepsis committee, and so I'm going to get these alerts on a daily basis of where providers, regardless of whether you're in an ER, hospital wards, ICU, OR, regardless, this is a patient who met the SIRS criteria, and somehow you missed the bundle. There was a defect in the sepsis core measure. And so it'll give you the MR number, it'll give you the date, and it will tell you, did the provider document that there was severe sepsis? You did that here, right? Did the patient have 2 or more of the SIRS criteria? In this specific case, the patient was febrile, they had a tachycardia, they had a leukocytosis, so the patient had even more than that. Did the doctor document that there was a suspected infectious source? No, you got a chest x-ray, but you didn't document that you thought it was a pneumonia. Was there evidence of end organ dysfunction? Sure, the blood pressure was low, the lactate was high, you can argue the creatinine was high. And so you missed multiple sepsis core measures. You didn't give antibiotics within a period of time. You didn't document why there was a delay in blood cultures. You gave blood cultures, you drew blood cultures after the antibiotic started. You didn't get the lactate within a specific period of time, and you missed the ball on resuscitating the patient with more than 30 cc's per kg within a specified time period. So how can we try to reduce these sepsis defects? What can we do as an institution or as a provider to be able to sort of be ahead of the game? Because clearly in this specific situation, you fell behind. So here comes SeptiCyte RAPID. When you Google biomarkers for sepsis, outside of procalcitonin, lactate CRP, really there's a bunch of them out there, but none of them are FDA approved. SeptiCyte RAPID is FDA approved. Then within just 60 minutes, just 2 minutes of handling time, it'll be able to analyze the gene expressions using reverse transcriptase transcription. And as we know, sepsis is a dysregulated immune response. The body is fighting itself. There are genes in the body that are being upregulated. There are genes in the body that are being downregulated. So this is able to analyze the upregulated gene, in this specific case, PLACA, and the downregulated gene, PLA2G7. And so it will analyze these genes and be able to differentiate sepsis versus SIRS, because that's what happened in this case. You had a patient who came here, they had a leukocytosis, they were tachycardic, they were febrile. Why draw just a CBC? Check a SeptiCyte RAPID with it. Because the problem is that when you check a procalcitonin, or you check a lactate, or you check a CRP, in the very beginning, when the patient is not overly septic, that number might not be elevated. That number might not be able to demonstrate to you that there is something outside of the norm, that SeptiCyte RAPID, regardless if the patient is in florid septic shock or the patient is just at the very beginning of sepsis, it will be able to capture that. You don't have to wait until the patient is severely decompensating. And so in cases of bacteremia, SeptiCyte RAPID was able to identify 100% of those cases. So the machine looks like this. It's a pretty easy machine to be able to detect. And so what you're going to do is you're going to get a number of bands. If you're in the band 1, there's a low risk of sepsis. As you move up with a score of more than 7.4, the likelihood of sepsis is extremely high. And so these are the common biomarkers that you're able to see. And as the patient has the top 3 biomarkers that you're collecting, it might not have an AUC that's very elevated, but look at the AUC, 0.86 of SeptiCyte RAPID. That's higher than anything else that's there. Whether you're using the top 5, whether you're using procalcitonin, or even if you add SeptiCyte to procalcitonin, you're really not getting that much better. This is a test that's able to demonstrate to you this patient is septic versus this patient is SIRS, and be able to start that bundle earlier, because that is not just trying to avoid those defects from the institution. We know that it saves lives. Acting earlier in septic cases saves lives. And that's our goal. So back to Mr. Jones. You ordered the chest x-ray. Maybe you did get a septic score when that chest x-ray came back. That test will have come back in 1 hour. And it gave you a score of 7.5. What were you able to do then? Now you're certain a lot faster that the patient is septic. You'll be able to get your procalcitonin in 4.5 hours, your lactate in 4.5 hours, your CRP, because these are things that'll take longer. The handling time is longer. Now you can get your blood cultures earlier. You can give antibiotics earlier. You're able to give your fluids earlier. And at the end of the day, your sepsis defects will not come back. And the patient hopefully will do better. What are our goals when it comes to sepsis? We want to give antibiotics in a timely fashion. We want to give fluids in a timely fashion. We want to provide hemodynamic support. We have to control the source of the infection, and we have to get blood cultures to be able to figure out where this is coming from. But in order to do any of that, you have to be able to recognize sepsis. And SeptiCyte RAPID can do that. Because if you just rely on SIRS, that's just an inflammatory response. We all know that there's a slew of things that can elevate or affect SIRS and be able to confuse that picture a little, whether it's an anti-inflammatory effect, a hormonal effect, metabolic, coagulopathic, autonomic effect. And if you were to just use the SOFA score, well, then we know that according to the SOFA score, that there's an increase in mortality above 10% when the SOFA score is 2. And here I've demonstrated the SOFA score, but even that isn't enough. Even if you make it the updated Q SOFA score, where you add altered mental status, hypotension, respiratory rate, it still does not allow you to differentiate sepsis versus SIRS. There's just too many things in there that confuse the picture. And SeptiCyte RAPID is one of those FDA approved things that can do that. Thank you.